Good evening. If you would go ahead and place your name and your campus in the chat, and we'll get started in about 6 minutes.
It says,
I didn't hear you, Miss Stacy. So good evening for those that are already in. Go ahead and place your name and your campus in the chat. Let's see. We still have 5. Miss Stacy, were you talking to me? You came off mute and I heard your voice, but I didn't hear what you were saying. No, okay. I'm not sure how that happens. Sometimes your computer just unmute itself, I guess. Or we're close to something that clicks it. So come on in. Good evening. Good evening. We do have 4 more minutes. Go ahead and place your name and your campus in the chat box. Good evening. We still have about 3 minutes. Go ahead and place your name and your campus in the chat, and we will get started in about 3 minutes. All right, we just have one more minute. Evening to everyone. Go ahead and place your name and your campus in the chat. Hope everyone is doing well. I know there's storms going through, seems like different places. One more minute and we will get started. Place your name and your campus. And just as a reminder, these sessions are recorded, including the chat. All right, so it's 7 o'clock. We will go ahead and get started. Hopefully everyone is doing well. So we do have several chapters that we will actually look at. We will look at chapter 5, 11, 27, and 14, I believe. I did post a recording for 2 chapters already. And if we don't get a chance to cover all tonight, I will still cover those and then post them. So just my advice to you is just look at the postings, 1 or 2 chapters at a time, and try instead of trying to digest all at one time. So you've already read through the chapters yourself, and so after reviewing the recordings, that will be the second time that you're reviewing the information, and that will help reinforce and ensure that you are understanding whatever that you're reading. Let me turn this other recording up. I'm logged in twice, so you do see me twice on the screen, because I was just being precautious in case something happens to one of my computers. I'll still be up on the other. All right, so again, go ahead and place your name and your campus in the chat. We will go ahead and get started. Chapter 5, Economics of the U.S. Healthcare Delivery. Now, if you all are running into problems where you can't hear me or see the screen or something, please put it in the chat or either send me a quick text message, because sometimes things do happen. So we do know that healthcare disparities are differences among populations and groups. And it's based partially due to the availability and the accessibility. For one, is the service even available in my area? Can I get it? For two, can I get to the service that's in my area? And then the quality of healthcare services that are aimed at prevention and treatment. Is it secondary healthcare services that are provided, or is it primary, or is it just tertiary? All those things will affect disparities in our health. Because things might be available, but those might not be the things that we need to address our need at that moment. We do have management of diseases. We do know that to manage diseases, we have to think about all the different complications that might occur, all the different stages of the disease process, including the screening and the diagnostic management and the rehab services. So that person, we have to consider everything from the beginning to the end. As a reminder, the goal of public health is to provide the most good, as we've said this several times, for the most people. So there is that gray area where some of the things that the government, the state, local government agencies, the different resources that are out there, some of the community partners, they might not address what that person actually needs. But the goal is to provide the most good for the most people. And we as nurses need to understand the basic economic principles to avoiding contributing to the rise in healthcare costs. We've been hearing that word inflation here pretty frequently in the news. So that does apply to healthcare costs as well. So if you're managing, for example, if you are the founder of some type of company that provides a healthcare service for someone, you would want to consider your costs, comparing your reimbursement for the services that you will actually provide. So you do want to, if you're for profit, you want to be able to, make that profit. Otherwise, you might not be able to stay in business. Let's see, this does mention, let me scroll down here, the GNP, the gross national product. It reflects the market value of goods and services produced in the United States. So we're hearing those words here pretty frequently. The GDP reflects the market value of the output of labor and property located in the United States. Okay, I think I got ahead of myself with the reading. How healthcare is financed and delivered has a direct effect on the ability of all United States residents to obtain timely and appropriate and affordable healthcare. We know if you've went to the urgent care and you've received a bill, you look and say, wait a minute, what did those people do to me? I just went for, sniffles. I just went for an allergic reaction. But even though you have that health insurance, many times you still will receive a bill because some of the service that were provided was not at that level of care for the facility that you went to. So how healthcare is financed and delivered has a direct effect on the ability of all of us to be able to afford and to seek out that healthcare. It has been recognized that social determinants, this is another word that we're hearing in the news a lot, social determinants of health, along with health behavior, they play a major role in the health of individuals and the families. And I actually have a little video right here. It's from the CDC's website that I want us to look at. And let me stop sharing for just a moment and pull the little video up. Scroll back. And we share again. Okay, now you can see it.
At HHS, we define the social determinants of health as the conditions in the environments where people are born, live, learn, work, play, worship, and age. Social determinants affect our health, well-being, and contribute to health disparities and inequities as well. Healthy People, our nation's longest-running disease prevention and health promotion initiative, emphasizes addressing the social determinants of health to create environments that promote health and well-being for all. I'm Admiral Rachel Levine, Assistant Secretary for Health at the United States Department of Health and Human Services. Healthy People 2030 provides a framework for thinking about the social determinants of health across 5 domains. Here are 5 social determinants of health. First, economic stability. People with steady employment are less likely to live in poverty and more likely to be healthy. By helping people earn steady incomes, we can achieve economic stability for all. Second, education access and quality. People with higher levels of education are more likely to be healthier and live longer. By helping students excel in school, we can improve educational access and quality. Third, healthcare access and quality. Many people in the United States are unable to get the healthcare services that they need. Increasing access to high quality healthcare services will ensure more individuals can attain their full potential for health and well-being. Fourth, neighborhood and built environment. Health and safety risks like high rates of violence and unsafe air or water impact health and quality of life. By creating safe communities, we can provide opportunities to promote playing and physical activity. And fifth, social and community context. Increasing relationships and interactions with family, friends, neighbors, and community members is beneficial to an individual's health and well-being. To learn more and see how others are working to address social determinants of health across the nation, please visit Healthy People.
There is strong evidence that suggests that poverty can directly, and it really does, is related to poor health outcomes. Just as a reminder, make sure you place your name and your campus in the chat and turn your cameras on. Remember, these sessions are recorded and they are reviewed. Go back to the actual book here.
I have a question about all of this Healthy People 2030.
Mm-hmm.
Did they did they take into consideration mental health and firearms? Because I think that's a big component that's missing here, because that's on the rise.
Exactly. And that is in chapter, I want to say 27, where they talk about violence. I think they did take it into consideration, but I don't think they thought about it in the way that it's actually occurring. So that's a great question. Yes. And so, yes. And so do we need to wait until 2030 to refine those objectives? Hey, they might not need to, because like I said, we're seeing an increase in those occurrences. That's a good point.
Yeah.
Anyone else? And that's a great point. Knowing that the evidence between poverty and poor health outcomes, there's strong evidence that suggests there's a direct correlation, a relationship between the two. Like, what are we doing as a society to decrease poverty? You know, what policies, what programs do we have out there to directly address those goals? You know, is it on, and then on the levels, you know, the state level, you know, in the communities, what are we doing to address that? So those goals are, you know, supposed to address the things that they know. You know, are they realistic? And then when you come up with your interventions, and as you actually interact with your different communities, you'll come up with all these interventions, but is it really impactful? Does it really matter for that person or that population of people? So you do have to keep that in mind. So poor health outcomes, they lead to reduced educational outcomes, poor nutrition, low productivity in the workforce. In 2010, a significant health reform law, we remember the Patient Protection and Affordable Care Act, it was passed with hopes of increasing the opportunity for people that wanted healthcare, that they could get healthcare, and they, you know, it would be affordable, because insurance is really expensive. And so that was created. And as a result of these laws and policies, there's so many bits and pieces of it. So it seems like it helped one thing, but then it had an attachment to it. For one example that I can remember is, like, if your employer did subscribe, you subscribe to your employer's insurance, if you didn't do certain, and I think I mentioned this before, certain things, for example, if you didn't go get your wellness checks besides your regular checkups, then you were deemed an extra cost. And so it was like, well, what is the need? You have the whole thing was making health insurance more affordable and accessible for people. Then once you got it, then it came with all this other stuff. So laws and objectives and all these things, I think they should be revisited and revised more than what they are. A move toward improving population's health and investment in public health should be addressed by all levels of government. Prevention and Public Health Fund, that was another entity that was specifically designed to invest in the public health in communities. So we got the Affordable Care Act and the Prevention and Public Health Fund. Public spending on healthcare, it makes a difference. Funding is highly variable from state to state. We do know, I don't know if you all have been hearing on the news, maybe not here lately, but maybe when the year first came in, where they were trying to expand Medicaid, and it was up to your state to subscribe to that, to accept the expansion. And as a result of that, more people in that state would have access to those resources. But if your state decided not to receive the funds from that, then, you know, it wasn't, you know, made available for more people. And it is a state by state thing. Some things come across the board for no matter what state you're in, but then some things they leave up to the individual states and local officials to decide, well, hey, we want to participate with this or not. But as a result of it, some of the, you know, people that live in that state are unable to. And on the flip side, you know, if you live in a state that did receive and accept those resources, then more things were made available. A baseline of prevention services should be provided to all, regardless of where they live. So the United States, this right here is an interesting fact. The United States spends more on healthcare than any other nation. The cost of healthcare has been yet the US population does not enjoy a greater longevity as compared with other nations. So other nations spend less than we do, but then they spend less, but then they have a lower level of, or a least amount of, or less occurrences of disease processes and the health span, the lifespan. So, but we spend more, but then it's the opposite. So you would think more would be better. But in this instance, at least according to this literature, it isn't. Economics is a science concerned with the use of resources. So you do have to keep in mind the resources and how, I got my head, the resources and the amount that you're spending on them. So for example, if you're that home health nurse or that occupational nurse, you have to think about, you know, when you're ordering supplies, do you really need the supplies that you're ordering? Yes, you can order Band-Aids, but are you really needing that many of them? Do you really need Band-Aids? I'm just using it as an example. So that's something that you have to consider when you are thinking about the resources. Here we go. Economics is a science concerned with the use of resources, including the production, distribution, and the consumption of those goods and services. So you do have to take into account, right? Is this something that we really need? And it might not be something that you really need right now, or if it is something that you need right now, think about, are we going to need this for in the next 6 months? Or do we just need this over the next 3 months? Health economics is concerned with how scarce resources affect the healthcare industry. And then public health economics then focuses on the producing and distributing and consuming of goods and services as related to public health. So we're thinking, hey, I just want to go in and take care of my patients. I want to do all I can for them, but you have to consider, you know, those resources. You know, how are you going to get reimbursed for those resources? Who's paying for those resources? So that's part of taking care of your patient. Americans with an income below the poverty level have a mortality rate several times greater than middle class income Americans. And they're linking that, and there are a number of reasons for that, but they're linking, for example, linking it to, if you don't have money for the insurance, then, you know, are you really going to go and get your well baby checks? Are you going to go and get your, you know, your routine checkups? Or are you going to just wait until something, you know, major happens? So, but if you have that insurance, not all the time, but most of the time, you'll go ahead and get those things done. And so that's why they're saying that the income level is related to an increase in mortality rate. Historically, the link between poor health and socioeconomic status result from poor housing, malnutrition, inadequate sanitation, and hazardous occupations. And then we can't get away from that access to health services. Is it available? And then if it's there, can I get to it? Can your patient, can your resident, can your participant, are they able to get to those resources? Is it on the other side of town? You know, if they are sharing a vehicle or if they have public transportation where they live, does public transportation go to that area of town? You run into that a lot. And so you might have to coordinate a different public transportation. And then there might be a fee with some public transportation. Medicaid is intended to improve access to healthcare. Although persons with Medicaid have improved access to healthcare compared to those that are uninsured, Medicaid recipients, they still have difficulty obtaining mental health services. And so that's another thing that should be addressed, because as we're seeing, you know, mental health is being talked about more. and in the realms of let's get some help for us, you know, for the you know, for those of us that need mental health services, and at least have it available. So that is being talked about. And also dental services. That's another big thing out there. One more is the hearing. I don't know if it's in your area, but they're passing this thing where, and I don't know all the ins and outs of it, but hearing aids are very, very expensive. And just think about it, if you can't hear, or if your patient can't hear, how they're really understanding the information, the intervention that you're giving them, the instructions that you're providing them. How are you receiving, if you have a hearing problem, how are you receiving the things that are being communicated to you? So, you know, they have all these little different hearing little aids out there, but they're not true hearing aids, but they're passing this bill or a law or something that's making it, from my understanding now, don't quote me, where they're making it more accessible, where people can, I think, not need a referral. And if you all know what I'm talking about, please chime in, so that they can receive that service and also be able to get those aids for lower rates, because they're very, very expensive. So they're addressing mental health, dental services, and now I'm not sure why they are, because I'm just wondering now if they have linked it to some studies or some findings where we've all been exposed to something and they know that we're trending to where more people are going to need hearing aids. It makes you wonder, you know, why they come up with this stuff.
Well, I think it's got to do a lot with all the use of the AirPods and all those little thingies that the kids use now, and they blast the volume. There has been a rise in hearing impairment and hearing loss at a younger, the ages keep going down and down. So I think that's what triggered all of this. I heard it on NPR.
Wow. And now that you said that, yes, that does make sense, because, and I just can remember, you know, just the other day, take those things out of your ears. You only need one in your ear. So yes, so they're seeing, and just think about where you work at, the different things, you know, we're so, you know, we have been so innovative. We've created all of these things, but I know in the environment that I work in, there's a lot of noise, you know, from those devices and things that they have made, as, you know, to help people, you know, have better health outcomes. So just think about that where you work at, and how is that affecting your health, right? Your hearing. And so you may be okay right now, but are they foreseeing, like you're saying, that iPods, you know, everybody has them. And for the most part, our babies, they have them in not just one ear, both ears. So what's coming? Were you going to say something else, Sandra?
No, that's all for now.
Okay. Yes, that was a great idea. But yeah, I did hear, like I said, I didn't get the whole part of it, but something about making hearing aids more accessible or affordable. It's like, okay, well, what's this all about?
Yeah, they're like $3,000, $5,000.
Very expensive.
Yeah.
Very expensive. Uninsured individuals have far worse access and outcomes, and they keep telling us that, like, what are we going to do about it? You know, what are us as a community health nurse, you know, what are things that we can, what interventions, what resources can we link or provide or make available? And if you're on that level where you become a politician, what laws and things can you introduce to, you know, help offset that? So we do know the primary reasons for delay or difficulty of failure to access care includes the inability to afford healthcare. Insurance is expensive. Even if if you buy the subscription from your employer, sometimes it's still, you know, a large amount of money out of your funds, you know, on payday. So you may or may not decide to subscribe to that service. And also, you know, depending on what insurance subscription you purchase, you know, some things are not covered. And then if they are covered, there's still a fee that you will incur after receiving that service. It's not that you get the insurance and hey, everything is all good from there. So, you know, it's many reasons why people may decide not to subscribe to the insurance. Let me just make sure I have all of these points I wanted to say. Primary reason for delay or difficulty in access is the inability to afford the health care, a variety of insurance-related reasons, including the insured not approving or covering the service that was provided. A big thing was that pre-existing condition. It's not more so, it's not a thing like it was a couple of years ago, because the Affordable Care Act was supposed to address that. Other barriers include lack of transportation. We talked about that. Physical barriers, communication problems, childcare needs. You know, I can go to the doctor, but I need someone to keep my children while I go to the doctor. And then refusal of services by providers. As we'll talk more about it, some providers, they do not have to render the service if in the event that you come in and they say, well, hey, before we bring you to the back, we need you to go ahead and pay this amount of money. And so you can't pass go, so to speak, without paying the fee. And so it is a passive way of refusing the service by the provider. In addition to lack of after hours care, I know they are trending toward, you know, like weekend care, and then clinics and things staying open on certain days, longer hours. And then, but as a result of that, then they are not open on a day, or the hours are shortened on another day. So, you know, they're trying to create some workarounds or make things more accessible or available to people. And then don't mention the long office waits when you go. Sometimes, you know, it just depends on what ends up happening. And then if most of the time, if a person has a, you know, bad experience, they may not want to return, even though they know they need to follow up on that, you know, on that chronic condition they have. They may not want to return because they had to stay so long, and then that prevented something else from happening or created a problem at home. Community characteristics also contribute to the individual's ability to access health care. For example, the limited prevalence of managed care and the limited number of safety net providers. Because reimbursement for services provided to Medicaid recipients has been low, physicians are effectively discouraged from serving the population. So, and like I said, they can do it in a passive way where they say, well, hey, you know, we do need this fee before we move forward, before we bring you to the back. The next thing we'll talk about is rationing.
Dr. Ford, what I've noticed with like Medicaid, it seems like they don't want to pay for anything that they don't really feel that's pertinent. Even though it's really pertinent for the person, they don't want to pay for it. So it's just my experience.
And that is true. That is true. And so what do we do about that?
Well, you try to work around it, but sometimes it don't work. But it causes this person that has Medicaid compared to this person with Medicare, they only get this type of dressing, and this person gets this type of dressing. In all reality, they both need the good dressing.
Exactly.
Yeah.
You know, why is that? Why is it that shouldn't be? Exactly. I do agree. And it is real. And it's things that we are experiencing. Our family members are experiencing. It is real. But what is the solution? What is the solution? Ran into someone the other day, and I don't know, we were talking about insurance, and they were currently unemployed because of something that was going on, but they were able to subscribe to Blue Cross Blue Shield. I'm not sure all of the logistics of it. And it was essentially free. And and the person went on to say, well, when they had a job, they couldn't afford it. And it was like, and she was like, and they were saying, wow, this is like, why is this? Why isn't this just made available for whomever that wants to subscribe to it at this free rate. It's real. And it, like I said, it affects all of us. Rationing healthcare in any form implies reduced access to care and potentially decreases the acceptable quality of services offered. We know that word ration, we give a little here, a little bit here, but it's not as good of a quality. An example, healthcare providers may refuse to accept Medicare or Medicaid clients, restrict the appointments available. You need to get in to your doctor, but whoever's making the appointments for that day have already filled up on their schedule. They only have so many. You don't know that, but they are the person that's trying to schedule the appointment. They don't realize that they only have so many appointments that day. That's for persons that have Medicare or Medicaid or private insurance or TRICARE and so forth. So then their access to care, it changes from day to day. If they call on a Monday, they have no one's called before you, before me that has Medicare or Medicaid. So then I'm able to get an appointment. But if I call that same time on the next week, I can't get in because they've already filled those appointments with someone. So access, it changes. And it's because of that rationing healthcare, and it is a real thing. As with access to care, rationing healthcare is a public health issue. Where care is not provided, the public health system and nurses must ensure that essential clinical services are available. We still have to come up with some type of intervention, a resource, seek out a resource, maybe a contact person that maybe knows someone that might know someone or something to try to help. We as nurses must plan for future changes in healthcare financing by becoming aware of the cost of nursing services. And we talked about that earlier. Because if you're that the person that's over materials, or you might be, that only person that's working as that occupational health nurse, you have to decide, and you're given a budget. You have to decide, what do you buy? So you would need to look at the time of year that it is. You might want to even consider the different activities that's occurring in your area, during a certain time of year, to decide, well, hey, we might have a lot of people out because they decided to go to the rattlesnake rodeo. I don't know, I'm just thinking of something. And as a result of it, we might see people that, I don't know, that are not able to come to work because they're needing to rest for 2 hours. And I'm just making up something. And so you might have to think about creating a space. And I know this is far-fetched, but think of creating a space so that the people that work there can have that time during the day to relax or get that, that downtime. That wasn't a good example, but you have to just be thinking about all that. That's, the time of year, is it the first of the month, the middle of the month, or the end of the month? What resources are you using the most of? We must plan for the future changes in healthcare financing by becoming aware of the cost of the nursing services, identify aspects of care in which cost savings can be safely and achieved with I don't want to say the same resource, but you want to have the best outcome for your patient. Nurses must continue to focus on improving the overall health of the nation. It is our duty. Okay, here we go. Let's look at these Healthy People 2030 objectives. Increase the proportion of adults who get recommended evidence-based preventative health care. I even thought about with this one, who decides those preventative health care? Who decides what those things are? Who decides that your Medicare, Medicaid, or your Blue Cross Blue Shield, your private insurance allows 5 visits per year, well visits per year? Why can't it be more than that? Let's go back to the drawing board. Let's revisit these things, before then. Who is that gets that ball rolling? And since we know that our children, even us, we're using these earbuds and things, and we're exposed to more things that might cause hearing loss, why isn't a hearing test included in the preventative service at this age and that age? I'm just making up some stuff. So, but that I agree with what you were saying about the hearing loss. And also the example that you gave about the dressing changes and the supplies, with a person having one type of insurance versus the other. Nurses must effect changes in the healthcare system by providing leadership in developing new models. Here we go. We have to be able to come up with new models. So it's on you all. Tag, you all are in. So be thinking of ways and different things that you can talk to your legislators about. With the increasing cost of healthcare and consumer demands and the changes in financing, the different financing mechanisms, excuse me, y'all, I'm getting tongue twisted here. Financing mechanisms, there's a new trend toward financing more preventative care services. So today, third-party payers are beginning to cover preventative service, recognizing that the growth of healthcare systems can no longer be supported. So they are beginning to cover those preventative services. Like, who in the world would have thought they wouldn't have covered preventative services? But that is a thing. Remember, primary prevention strategies aimed at an economic issue is to work with the insurance company to provide the necessary coverage. So we're going to talk about the different eras here in just a moment. Looking at my notes, making sure. Got all that. Okay. The first developmental era, the 1800s to the 1900s, was characterized by epidemics of infectious diseases. Health concerns of the time related to social and public health issues, including contaminated food, water, and supplies, inadequate sewage, disposal, and poor housing conditions. The practice of medicine was unregulated. Family and friends provided most healthcare at their homes. Hospitals were few, and then people didn't want to go there because it was like overcrowding and conditions were unsanitary. Sick persons who were cared for in hospitals, they were often, like if you go into that hospital, you're not going to come out alive. So sick persons who were cared for in hospital often died as a result of those unsanitary conditions. This was in the 1800s, 1900s. So most people avoided being cared for in the hospitals unless it was no alternative. Isn't that something? The people didn't want to even go to the hospitals. In this first developmental era, healthcare was paid for by individuals who could afford it. And remember the black bag? I don't know if you all recall the black bag that the doctors had. It contained few medicines and tools that they could provide the healthcare. The second developmental era, we're evolving, the 1900s to the 1980s. Delivery was focused on the control of acute infectious diseases. So environmental conditions influencing health began to improve with major advances, water, purification systems, sanitary sewage disposal.
Then again, also antibiotics, right? And vaccinations.
Exactly. Hospitals, they began to experience increasing growth because they started to clean up stuff. They gained more knowledge and understanding, and they made those changes. And then we have the evolution of the public health departments. So then we have the introduction of the Social Security Act in 1935. And then we have an increase in technological advances. And then, like you mentioned, antibiotics. Okay, and then we're down to the corporate area in 1980s to the 2019. has been a period of limited resources with an emphasis on containing costs. Isn't that something? Now they're worried about the cost. Things are just costing too much. But you want to exhaust all means to, for your patient, for yourself. You want someone to exhaust all means, but their focus is on containing the cost. They made amendments to the Social Security Act. And that's when they came up with the DRGs, the diagnostic related groups, and those prospective payment systems. They went to more so that coding, if the doctor documented that they removed the toenail off the left great toe and they provided a dressing, that's all, if that was documented, that's what they got reimbursed for. But those things were not documented. If, for example, they removed the toenail off the left great toe, they didn't document, they put a dressing on there, and they also gave a tetanus shot, then those things were not understood if it wasn't documented, and that person that was abstracting the information from the chart, then that doctor was not reimbursed. And it's
They will
not
pull money back. They will pull money back when the documentation's not there.
that is true.
Yep.
And then as a result of that, who gets the bill?
The company, well, if they're in a
Patient.
community, they would.
The
But
doctor sends the bill to the patient for whatever the insurance doesn't cover.
Yes. So I am going to pull up my little jam board here. We're gonna be a little interactive here. Move us up here. The jam board, as you can remember, I'm going to place the link in the chat box. You're going to click on it and you're going to interact with it. Let's see here. Okay, and let me copy the link. It's in the chat. So just click on the link. You should be able to go in and click the sticky note and respond. If not, let me know. I made you all editors. So make this large. So, and I just want you to respond here. Society has an obligation to provide healthcare services for people who are poor, underinsured, and uninsured and underinsured. So one, you have insurance, it's just not enough for whatever chronic diseases and things that you need. And the other one, person doesn't have any insurance. How does the economic status of these groups affect their access to care and receipt of healthcare services? If I don't have insurance, how does that affect, my access to care and the care that I receive? Uh-oh, trying to make it smaller. Let me stop sharing. Let me just hear your responses to that. So once you click the link, you go in and click the little square to the left. That's a sticky note. And then you just type your response. We'll give you a few minutes. And this is real. If you haven't experienced it, maybe a family member have, but it is real. What do you do? I'm trying to make this smaller. Let's see. Society has an obligation to provide healthcare services for people who are poor, underinsured, or uninsured. How does the economic status of these groups, if we're saying that we are for the greater good, why is it that I have a different experience if I do not have insurance, or the insurance I have is not the platinum insurance? How does that affect my access to healthcare and then me receiving that healthcare. Uh-oh. I'm trying to make my little sticky note smaller, you all. I don't know what I need to do. Make it small, like it's taking up all the space. Okay, there it is. There we go. So we'll give you about 2 more minutes. There we go. All right, so as you all continue to respond, give it a few more minutes because I want you all to give voice to what you've actually placed on the sticky note as well. So explain or discuss what you've placed on the sticky note. All right, who wants to go first?
I think you already talked about it, but we did say that the people who are underinsured have a tendency to just go to the ER for their day-to-day care because they aren't necessarily obligated to pay the bill.
Yes, comments on that? Yes, and if you,
Especially the homeless population.
Yeah, I actually do have some family members that do that. They don't have insurance and they go to the ER to not just when they feel bad, but if they feel bad, then they go to the ER and then they also tell the healthcare providers, like I might go for an ear infection and I might say, oh, but then last month I had this and that. So they want to address all the issues they've been having, apart from the acute one that brought them to the ER.
thank you all for sharing. Next, or a comment?
They wait until the illnesses are critical to go see the doctor to begin with, and they're far less likely to get preventative care in any way, shape, or form. So somebody who knows that they have diabetes will not go and see a doctor until they're in DKA to the point where they need to be hospitalized.
Thank you for sharing. This is real. Like I say, you know, we have experienced some of this, and if not, we know someone that has. It is real. Next person, someone else share.
I just said that if you don't have the money or the insurance, you don't actually get the proper care. You'll get minimum care. It'll be to a minimum. Like if you go to the ER, you don't have insurance, they might care for you, but you're not going to get priority care. You're going to get minimum care. As
they
somebody
might
that
not
had insurance, they're going to do blah, 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 this test, that test, and treat you for this. But another one, it would just be a minimum of a test or something.
Well, when I was in the ER the other day, we did focused assessments. So the person would come in and they would tell us about their acute problem, and we would do an assessment based solely on that focus. So like somebody who needs to go see a doctor for whole body, that would get missed if they just went to the ER to go get their acute problem taken care of. So yeah, that's a good point, Sherry.
But even so, the ER is mainly for like stabilization and whatnot. So if you go for your back hurts, they're not gonna look at anything else besides like the back pain. So they're just like pumping and dumping pretty much.
The
Okay.
ER is for like focused care. You're not going to go to get a head to toe assessment. If you're going to come in for back pain, that's what they're going to focus on. Usually your ER is for acute and priority care, as well as I mean, if you come in, they're going to do all the tests that they can. They're not going to just pick and choose. They're going to treat you on based on what your chief complaint is. It don't matter if you have insurance or not.
Anyone else?
Well, to me, the ER does, even though they don't do much of like, they're like more focused screening, where they would screen patients based on whatever. Some patient might come in for one thing, but end up being admitted. So it also includes a screening process. That's how the hospitals end up, full most times, because you may come in for just something minor and then they run some labs and you ended up being admitted because you might be heart failure, or it might be something different, something more severe than you expected.
Okay, thank you all for sharing. Anyone else before we switch to our next activity? Anyone else? And sometimes, it just depends on the time of the month for the person, if they are uninsured or underinsured, and they're given a certain amount of supplies, whether or not it's a colostomy bag or insulin syringes, or insulin, or, different supplies that they may need. They have found out, hey, if I go to the ER, they most likely will give me or change that bag or provide something for me. So without receiving, they can go past go. They can go past that front desk and still get that care or a remnant of that care that they're trying to get until the next, cycle of medications or the next cycle of colostomy bags come in. So you'll see that too. And like I said, we may have, some of us may have experienced it ourselves or know someone that has. So what can we do about all of this? What is it that we can do? Is it anything that we can do? All right, and so the next thing we're gonna do is look at this case study. Gonna share my screen here. Let's look at these levels of prevention. So what level are you on? So if we're working with legislators and insurance companies to support the Affordable Care Act coverage for health promotion services to reduce the risk of disease, which level are we on?
Primary.
Primary.
Do we agree? I see heads nodding. Okay, I do agree with that one. So participate in home visits to mothers who are at risk for neglecting or abusing babies to reduce the costs related to abuse and neglect by providing guidance and education on newborn and postpartum care. What level are we on?
Tertiary.
I see heads.
The abuse hasn't happened yet, so I'd say still primary.
Has it happened?
They're at risk for neglecting or abusing babies. They haven't neglected or abused their babies yet.
But it says, or abusing babies to reduce the cost.
Yeah, they're visiting mothers who are at risk, not who have abused their babies.
So the first part, who are at risk for neglecting or actually abusing babies, is how I'm reading it. The first part, they
That's
may
what it says, or.
yes. So something has actually happened in this one. So would we say it is tertiary? I do see what you're saying,
Tertiary.
Michelle.
Tertiary, because something had happened for that to trigger this
But if this,
intervention. So it can be both.
It's not a separate sentence.
so if abusing babies was not there, they're at risk for neglecting the babies, what would that be?
Same, because it's the same sentence. They're just using the word or.
So I'm seeing it as, and I'll refer back to the book, they're at risk for neglecting or they're actually abusing the babies. So let's refer back, because that's what I'm thinking it is. So we shall look, let's see here. What chapter was this? Chapter 5. Let's see.
Our book like sends us to the website to get the answers on all this stuff, and we don't have access to the website.
No, this was actually in the chapter though. This one was. You all are, excuse me, you all are looking and thinking about these levels of prevention. Y'all are rocking, thinking it through. I hear your thought process. Let me get to it. I pulled that one right out the chapter. I didn't go to the additional resource. Let me just let's see what we got here. Trying to get to that page. Scrolling. Almost there. Okay, nope, that's not it. Not that one. Here we go. All right. So let's see, who are at risk for neglecting. I can see what you're saying though, Michelle. It does say at risk. So you would think you could. So that wasn't a good example. So would we all agree that if this would say at risk for neglecting or at risk for abusing babies, that it would not be tertiary?
Yes.
Okay, but if it's saying at risk for neglecting or actually abusing the babies, that it would be tertiary.
Yes.
Okay.
I think another way to look at it too for the tertiary is that there's a reason they're at risk. So that already puts them there at that potential for the risk factor to be the tertiary. That's the way I looked at it.
Good. Anyone else?
Yeah, I agree with how Sherry was saying it, because that's the way I looked at it. If they're looking at it, it's because something happened or they're looking to reduce the risk.
Great. Thank you for sharing. Anyone else? Okay, let's look at this case study, then we'll move on to the next chapter. On the same page here. We'll give you a few minutes to read through the little scenario, and then we'll look at the question.
Probably the long answer.
Michelle, why do you say the long answer? What's your thought process? What's your test taking strategy? Why did you come up with that?
Michelle,
I don't know if she's not moving. So is that a test taking strategy, you all? Or should we just still read? We're gonna read the answer to
I
it.
say it's A, but not because it's the longest one.
What else are you all saying? Is everybody agreeing that it's A? Not because it's the long answer.
Yes.
Do we have anyone that is saying otherwise? Let me stop sharing. I see a message in the box here. Let's see. Okay. All right. So we do agree. I think that was like an ACT strategy or something. Pick the longest. Have you all heard that before? The longest answer choice.
It works for
Longest
her.
or the shortest?
It works for her. Don't let her. It works for her.
I think I remember that from somewhere. All right. So number 2. Let's look at number 2. What are we thinking?
The third party insurances, does that mean like the insurances that employers provide?
Or you can subscribe on your own. Yeah, too, on your own.
Yeah, I think for number 2, I think right now, because of where I work and what they're doing, like the wellness stuff and stuff, I would say C.
I see a lot of heads going up and down. So we're agreeing with third party. Okay.
What is D? What is D though, Dr. Ford?
So I don't know if it's a program, but for the most part, in doctors' offices, they have like I don't want to say unspoken list, but if someone, they have so much per day, they're not all doctors' offices, but so much per day of free services that they can provide. And so if a person comes in and, they meet whatever those requirements that they have listed, then they just provide that care free service for that day. Heard of people getting video. Go ahead.
Where I work, they are, since it's a nonprofit healthcare system, they are obligated to allocate a certain amount of money a year for charitable healthcare services to community members. And I think it's up to somewhere like $200 million because it's a big healthcare system. And it's
that'd cover about 3 patients.
and it's like the same thing with attorneys. They have to do a certain amount of pro bono cases per year as part of to keep their licenses and stuff. So it's the same thing with healthcare systems and with doctors, except that doctors don't really market it.
Yeah, that's why I say it's like an unspoken thing. They don't really
Yeah.
market that. Yeah. Okay. Anyone else knows about, like I said, I don't know if they're using the word indigenous there, but they call it something else from what I remember, but I can't remember what they actually call it, but it's like an unspoken list. And have you ever heard people say, hey, I got this bill, but then I got a letter attached to the bill that say, hey, this has been taken care of. And so that's pretty much what happened. But it's not like something that's advertised. Okay, and I'll next to the last question for this case study, how can home care nurses plan for future healthcare financing changes? Select all that apply. And you all can just shout it out, which ones you think are correct.
B.
Oh, it's to select all the apply. I think it's B.
Mhm.
A.
A.
I mean, you don't know what you're saving or spending if you don't know.
So we got B and A. Any other?
Sorry.
I'm kind of torn with C. I believe I agree with her, A and B. I think C might be one as well. I'm not sure.
So what do we think C is talking about?
Pay attention to the newspaper articles about economics and healthcare.
Like the
Well-
prices that might be going up or medical equipment or services, did they go up? Did they rise? I'm thinking that's what that means.
And, you know, services that maybe benefit their patient at home that can decrease some of the costs for home. That's kind of the way I look at that.
To me, C means where the community and its members, where do they spend the money? Would they rather spend it on preventative or healthcare at all, or would they rather spending on you know, consumerism like we are on goods, on, you know, cars, homes, clothing? That's what C means to me.
Anyone else? So why would we not select D, decrease the number of nursing visits provided in home care?
It doesn't benefit the patient.
In the long run, it's gonna cost you more because the person you're not being, you know, they're not being taken care of. So it's gonna cause more problems, okay? What about E, decrease the utilization of other disciplines in home care to reduce costs? Why would we not want to select that one?
You'd
The
want to
same thing.
do the opposite, right? You'd want to increase the utilization of other disciplines.
Good. So when you are taking your exams, these are things that you can do when you're trying to select the, you know, the answers. You know, read the answer choices and say, hey, well, I know this is this, that makes sense, because this, we're wanting to see this outcome, and this is doing this will end up with the opposite outcome. So that's good. Great. Like to hear how you're thinking. All right. So we're gonna move on to our next chapter, and no fear. Once I know our time, we only have like an hour left. I'll actually stay on and finish recording the rest of the chapters so that you all can have that accessible to you. So I do have 11:27:5, and I think we'll be caught up to after reviewing those. But I don't want to quench your thought process and your learning process by just speeding through, but I will cover those because I know we're not going to get to all of those. And I do have like case studies and a Jamboard for each one of those, and I'll just kind of put that up there as I'm recording myself and just kind of interact with myself too at the end. So I'm not going to ask you all to stay over or anything because that's not, we're not going to do that, but I will record and cover those. All right, so let's move on to our next. And I haven't given you all time to stand up, and so let's just do a 3-minute break real quick. Stand up, get you some water, you know, move around. Break. Timer for 3 minutes. All right, so infectious disease prevention and control. The successful interaction of infectious, remember the epidemiological triangle, remember that the agent, the host, and the environment. It is necessary for disease transmission. Knowledge of characteristics of each of these three factors is important in understanding the transmission, the prevention, and the control of diseases. Effective intervention measures at the individual and community levels must be aimed at breaking the chain linking the agent, the host, and the environment. So we must be constantly aware of those different threats, those emerging infectious diseases. You know, that's, we mentioned before when we were talking about the CDC and the World Health Organization, someone's keeping up with all of the different occurrences of disease processes going on. And the WHO is like the go-between that says, hey, you know, you all, we're seeing this over in this country. And so you all need to go ahead and be looking at stepping up your interventions and putting those troops on the ground, putting those commercials out there, making people aware of, hey, we're seeing this, but what can we go ahead and do about it? You know, in a realm of being proactive. Communicable disease prevention should include providing drug treatment and vaccines, health promotion and education by way of aiming to change individual and community behavior. So nurses, we play an important role in all aspects of prevention and controlling those communicable diseases. As we saw with COVID-19, that we set up the clinics outside of the clinic. People were doing the Zoom calls. The telehealth became, you know, it was a thing, but it started booming. So people start putting, you know, start educating, providing, for the most part, that primary prevention, saying, hey, stay that 6 feet apart, wash your hands, cover your mouth, cover your nose. Concern about infectious and emerging diseases have grown since 2020. And we knew about them before then, but like never before, it was like, okay, what do we need? What's next? What do we need to do to prevent this? So the least little thing we hear about, people are wanting to know, you know, who is it affecting? How is it affecting them? How are they getting it? What's the mode of transmission? What can we do to prevent it? Although not all infectious diseases are directly transferred from person to person, the term infectious diseases and communicable diseases, they're used interchangeably. Okay, let's see. Let's look at box 1111. Those 6 characteristics of an infectious agent. 11.1, I'm sorry, 11.1. So as we're providing that education, as they're coming up with interventions, you know, they have to consider, you know, what is this infectious agent, you know, most likely to do? How is it able to infect? So they have to consider that. The host factor, a human or animal host can harbor an infectious agent. The characteristics of the host may influence the spread of disease. Are host resistance, immunity, herd immunity? Resistance is the ability of the host to withstand infection, and it may involve natural or acquired immunity. We kind of talked about the herd immunity in another chapter, but this one talks also about the natural immunity. It refers to species determine the innate resistance to an infectious agent. So for example, they give the opossums, they rarely contract rabies. So it's just like the way that they're made up, so to speak. Acquired immunity is a resistance acquired by a host as a result of a previous exposure. Then it breaks it down, talks about the active immunization and then the passive. So the active immunization refers to the immunization of an individual by administration of an antigen. Passive refers to through the transfer of a specific antibody from an immunized individual to a non-immunized individual. So an example is that is a person receiving like the immunoglobulins or the anti-serums. We talked about herd immunity. I do remember us talking about that. So what do we remember about herd immunity, you all?
It has to be at about 90% to be.
So the amount of people, it is a large number, but it is a thing, but you have to reach that certain number is what they found in order for it to actually occur. Someone else was saying something.
But
So-
does it have to be 90% of the people before it becomes an epidemic, or 90% of the people that have been that haven't been exposed to the pathogen? Or because that was my confusion with the whole COVID-19 thing. Like Dr. Fauci was saying, you have to quarantine and you have to get, I don't know how many people that whole herd thing, for it not to contain it. So it was very confusing to me, the whole herd thing.
Anyone else want to comment on that?
Let's see. So if the majority of the group has been vaccinated against something, if that particular strain that they've been vaccinated against attacks the 10% of the community that is not vaccinated, the spread of the disease will go a lot slower because the people who are vaccinated will not spread the disease as far. But like with COVID, strain keeps changing, and so we keep needing to go get new vaccines over and over again, which is something they may not have realized back when COVID first started. So if you haven't been paying attention to the, you know, the Delta, the Omicron, yeah, it can get really, really confusing, and a lot of what they told us to do didn't make a ton of sense, but they didn't know that at the time.
But really, how is that any different than the yearly flu vaccine? Because every year the flu changes strains, and we get last year's flu strain vaccine when they.
Well, even if the flu vaccine is a year old, that strain is still floating around, which is why you would still get it. And sometimes the strains that are new are similar enough to the old ones that you still have some sort of partial immunity from the older vaccines that, you know, helps you at least fight a couple days earlier the new strain.
Right.
So it's useful. Also, I mean, COVID-19 literally is 10 times more deadly than the flu.
Right, I'm not saying it's not.
Yeah. Oh yeah.
But I'm just saying, like, as far as the immunity and the vaccination statuses and that sort of thing, I feel like some of those, you still have some of those antibodies if you.
Oh yeah, and you do. Anything that your body has fought, you have an antibody for. It'd just be nice if you had a little bit ahead of time to fight it to begin with, you know. But like the way we do things here in the United States is pretty complicated, you know, so it can get confusing at all the stuff that they're asking us to do.
So what do you say to the person, I got that flu shot and I still got the flu?
It doesn't prevent it.
I have seen people that have not. I know one person that didn't get the flu shot and she got the flu, and she ended up with a tracheostomy. I mean, it could be pretty devastating. So I have gotten the flu shot and I still have gotten the flu, and it has still kept me at home for a week. Being at home for a week versus being in the hospital intubated for 20 days and then trach. I mean, you know, I'll take the vaccine and I'll take getting sick but not being, you know, like a life or death situation that I saw.
I don't think the vaccines actually prevent it. I just think it helps prevent you from getting the symptoms as bad.
Right. Well, it's like the chickenpox vaccine. You get it and they tell you, well, if you get the chickenpox, it won't be as hard
bad
as if you wouldn't have gotten it. So,
right.
Well, it takes like 4 or 5 days off of the illness because your body already has some, and you're just taking a couple of extra days that your body would have been using to figure out how to fight the illness to begin with. So yeah, you're still getting ill, just far less.
yeah.
Anyone else? I got the flu shot and I still got the flu. Something one of you all mentioned earlier about the different strains. So I got the flu shot and I still got the flu. So what's in my flu shot? Did it cover all the different flus that were out there? I see Michelle has her 3 fingers.
No, it's different strands, so it's not going to cover all the different flus.
Exactly. Good. Thank you for sharing. So that would be some information, some education you would provide. Yes, you know, it only protects against this, but you still build up some immunity, still took some sick days off your illness, you know, but it didn't, the strain that you probably were infected with is more than likely was not the strain that was in the shot that you got. So good, 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 good. All right, so looking at the environment factor. The environment factor refers to the physical, biologic, and the social and cultural factors that are on the outside to the human host. So an example that they give is using the mosquito nets and the repellents to avoid the bug bites, installing sewage systems to prevent fecal contamination of water supplies, and washing utensils after contact with raw meat to reduce the bacterial contamination. So for modes of transmission, infectious diseases can be transmitted horizontally and vertically. And so for the vertical transmission, it occurs when the infection is passed from the parent to the offspring. And then if it's a horizontal, it's from person to person. Infection refers to the entry, the development, and the multiplication of those infectious agents in the susceptible host. So what do we remember about this incubation period?
The infection is replicating in your body. But it hasn't caused damage yet.
Anyone else? So that little invader has invaded, but there's a time before those signs and symptoms actually start to appear. It's like it's there. You are infected, but it's not showing evidence just then. And it's different time frames. So the agents of bioterrorism, both the attacks of September the 11th and the subsequent attacks of anthrax. Remember, they were sending things through the mail. People were getting the envelopes that had the white substance in it or something in it. And, you know, they were talking about bioterrorism. What do we remember about that?
Was that the anthrax?
Anthrax.
I don't remember much of it, but I do remember the envelope, the powder, that it was bad, but I don't remember specifics.
They were sending it through the mail. A lot of it was being sent through the mail.
So yeah, there were reports that people were dying as a result of opening up their mail. Like, what in the world is going on? They went to the mailbox. They were sitting on the couch or the front porch going through the mail, and the person, you know, fell dead. And I'm just, you know, speaking in a gist of a way. And so they had to examine, like, what is going on? Doing a head-to-toe assessment. What is going on with this person? And then they found out, hey, someone Because anthrax, is that just somewhere, that's just something that we just get out and about at the gas station, or, you know, going to the Walmart, touching something else someone else touched? So where does anthrax come from?
Like
Beans,
raw
right?
food, like raw pork or something like that.
Animal hides that haven't been tanned.
So it is found naturally in the soil, and it is not spread from human to human, typically from just handling. That's what it says. It's not spread from human to human, but typically from handling products from infected animals or eating undercooked meat. So,
But didn't they mix it with something else that made it the power that it was?
yeah, I'm not sure how they got it in that format, but yes, it was appeared as some powdery substance on the paper, the envelope. And then those spores got into the person's body, and it was deadly. Because, you know, they didn't realize they had been exposed to anything. So it was, you know, however many hours later. So, but that was just the crazy things, like, what is going on? Being afraid to go and get your mail. But that's, you know, that's bioterrorism. So then we talks about smallpox too in this chapter. It's formerly a disease found worldwide, but it's pretty much been considered as being eradicated. Smallpox has. Vaccines are good, again, are one of the most effective methods of preventing and controlling communicable diseases. What do you think about that? Vaccines are one of the most effective methods of preventing and controlling communicable diseases. And we're not vaxxers or anti-vaxxers, but what are your comments on that? What do you think?
It's pretty cheap and it works.
We know.
I think it might be the most effective way of preventing it. I mean, at least it's something, but I don't agree with all vaccines, but I think that it does help prevent it from spreading.
So they do have that immunization schedule for children's, you know, ages from birth to 15 months and 18 months, all the way up to probably 18 or 19 years of age. They do have those recommended list of immunizations that people should get.
I told you about my grandma, Sherry. You remember I told you about my grandma who lost 10 out of her 15 kids around the turn of the 19th century? 20th century.
Yeah.
Yeah, she lived in Colorado. She moved to Kansas, but she lost 10 out of her 15 living children to diseases that are probably now curable. Matter of fact, at some point, she opened up an old toy box of her kids, and another batch of kids got sick and died from it. It was horrific. So yeah, vaccines work.
Yeah, I'm not saying that all my kids were vaccinated. I say I don't believe in all of them, but I do believe they're there and they do help prevent disease from spreading. I think vaccines have made a difference in the last centuries and centuries.
Anyone else? Like I said, we're not, you know, debating. We're not anti-vaxxers and we're not promoting, you know, vaccinations. Any other comments? You know, if you agree or disagree, it's okay. This is a safe space. So measles is a disease pretty much you really don't really hear much about either, but measles is mentioned in our chapter as well. And a lot of these diseases, the symptoms are like the fever, the runny nose, person just don't feel good. But with the measles, you get that rash that's all over the body. And they do get those spots inside of their the mouth. And it is considered as being contagious. The rubella is one too that you really don't hear many people, you know, getting as well. It's a virus. It causes a mild febrile disease characterized by those swollen lymph nodes. Children may show few or even no symptoms with this one. And the pertussis, they were talking about the pertussis, that whooping cough, not this year. I want to say maybe 2 years ago, they had started back talking about that one because they were seeing, an increased number of people with that, the whooping cough. Over the last couple of years, I've been hearing that one. And that sound is a distinct sound. That person's coughing that has that. It is highly contagious. And we just talked about the flu vaccine, the influenza virus, talked about that. It is, its transmission is airborne. You come in contact with those droplets. And then the outbreak is usually, in the winter months. So it's almost time now for them to start advertising, hey, get your flu shots, get your flu shots. And there are 4 different types of influenza virus. Let's look at box 11.3, those foodborne and waterborne diseases. So 5 keys to safer food. So let's just look at those. Never really thought about not keeping separate the raw food from the cooked food, but it must be something that they found out that, that people do. But I never really thought about that because usually the cooked food is going the opposite way of the raw food. But so that's some education that we need to provide. Okay. Salmonella. It's a bacterial disease that affects the intestinal tract. And that usually is seen pretty readily on, but then, a couple of hours. And I want to say it was something in the news either yesterday about a group of people, I don't know which state it was in, but a lot of people were sick and they were trying to see, was it related to, the consumption of some type of food. And I didn't hear the whole thing, but people were experiencing those GI problems, the diarrhea, the nausea and vomiting. So we do have E. coli. It's normally found in our intestinal tract. But an overgrowth is something, too much of it is when it starts to cause problems. People usually see the stomach cramps, the bloody diarrhea and vomiting. And it's most associated with contaminated food or water and, undercooked beef and things like that. So there's often person-to-person transmission in daycare centers. And it says petting zoos. Waterborne disease outbreaks, they usually enter water supplies through an animal or human fecal contamination and often causes the enteric disease. We talked about the Lyme disease in another chapter. I think we did. So that is directly associated with the tick, but right here it says parents in Connecticut were concerned about the unusual incidence of the children getting juvenile rheumatoid arthritis. And that's something, and that's when they start investigating. It's like, wow, all these children, what do they all have in common? What's going on? What time of year is it? What events are going on? And so they had an increase in incidence of the children getting the rheumatoid arthritis. And so they linked it to those ticks, Lyme disease. So malaria, we really don't really hear about that much often, but it is a mosquito-borne disease. So again, people with that actually experience the fever, the chills, and flu-like symptoms. Okay. Foodborne and waterborne diseases can be avoided if people eat thoroughly cooked foods and that the food is prepared with, good hygiene. So those that are preparing the food are being clean, washing hands after coming, leaving the restroom and things like that. So rabies is one of the most feared of the human diseases. To date, there are fewer than 10 cases of human survival from someone getting rabies. And so we do know that they have these rabies clinics. They're out like the first start of summer, where people can just bring their animals and they get the shots and everything. But you still have to be, if you're camping, you'll be mindful of those wild animals, the raccoons and the foxes and things like that. Okay, and let's see, let's stop sharing. See here. Okay, here we go. Let's look at the levels of prevention and another case study. Which level of prevention? Immediate treatment of a foodborne infection. Immediately treat any foodborne infection.
Tertiary.
I see heads going up and down. Okay.
Tertiary.
So we agree, good, because that person has that illness. Okay, what about educate about safe food handling practices in the home? Oh,
Primary.
did I leave the answer there?
Primary.
It says secondary, but wouldn't that be primary?
I think I left it there, but it's not. It's yeah, you're right, you're correct. It is you're providing the education. So yeah, it is primary. Yeah. Yeah, I forgot to take that off. So immediately evaluate the possible source of any foodborne outbreak.
Tertiary.
Do we agree with that one? Is it tertiary?
I think so.
Don't pay that any attention with this being there.
It's not secondary and it's not primary.
It's tertiary.
Okay. Let's verify that. So what is your reasoning by saying that it's tertiary? Because of what?
The outbreak has already occurred.
Yeah. Okay, let's look at this little case study right here. I think we just have 3 questions for this one. We'll give you about 3 minutes to read through it. Let me stop sharing and make it smaller so you can see it on the. Let me share the screen real quick here. Are you all seeing that? It's not showing me that you all can see. Yes, because usually give me that message. Okay, here we go.
There you go.
Huh?
Yeah, probably B.
Okay, so you all can see the whole screen. Okay, all right. I'll make it smaller.
Or maybe C.
I want to say A.
I think D.
No, you can apply for an exemption to get into school anyways.
I know. But it's the way the questions ask. what is Mr. Brady aware of with regards to the immunizations of the students in the community? That's just the way I look at it.
So let's approach it from which one? Let's look at every, we've heard A, B, C, and D. So let's just start at the top. A, is that correct? Is that a correct statement?
No,
So you can't, the parents can claim the religious exemption and their children can still go to the school. So we eliminated that one. Let's look at B. Inner city children have higher rates of vaccination because of the free clinics that are offered.
I think that were true, that'd probably be more closely linked to the transportation, because people in rural areas would have a harder time making it to the free clinics than people in the inner cities.
Because they're right there. Okay. All right, so we can eliminate that one. Let's look at answer choice C.
I heard something along the lines of like 90% of people are immunized by the age of 13. Or is it 98%? So I know this one's true.
Adolescents have a higher rate of vaccination. So if you're saying by the age of 13, is 13-year-old considered an adolescent?
Well, yeah, I mean, somebody who's 13 or 14, which is adolescents, is more likely to be immunized than a 5-year-old.
So let's look up the age of an adolescent.
I don't think any of the answers are right. That's
let's throw them all out. So how old is what you're saying is correct, but the adolescent part, how old is an adolescent? That's the part that's
between 13 and 19, yeah?
Yeah.
I thought adolescents were older than that. Look it up.
No, adolescents are
5 to 12.
Look up adolescents. Let me see.
Well, adolescent would be like from the age of sexual maturity to about 18 or 19.
So they're, oh yeah, they're
10 to 19 roughly.
okay. So they're like the older part. So when you're saying 12 and 13, that is correct. They're the ones with the higher vaccination rates. But to me, they're not really considered as adolescents yet because they're still more kind of younger. So what about ethnic groups are at risk for incomplete immunizations?
They are. Because it could be.
Would you say maybe somebody from a community that doesn't speak English is less likely to have their children vaccinated because they might be afraid to go seek health care?
What else? What else are we thinking about D? Sherry said throw them all out. We need some new answer choices. We might have to agree with her.
The answers don't go with like the question.
I agree with
An
Sherry.
ethnic group could also be like the Amish, for example. I don't think they go big for vaccinations. I could be wrong.
I mean, it could be all of them really, other than like the kids can still go to school with exemption, but it's really not specifying what they're actually looking for. That's my problem with it.
So while he's doing his, his daily due, he's just thinking about, some challenges that people might face. And so in thinking about that, who just said that? I think it was Michelle. Thinking about specific people or ethnic groups, like you said, the Amish may or may not, or so forth. So if I had to pick one, I would pick D, because being, just thinking about, who would have a challenge or who might not, who would be least likely to, then you would drill down to, certain ethnic groups and, what they do or don't do, whatever their practice is.
I like to see what the answer is.
They're saying that it's D. Like I said, if you have to just think about it, just trying to just down the person or the group of people that would least likely So no, just being more aware of, hey, this certain age of people or group of people might say, hey, I don't want this done because of, whatever it is, the reason. We knew you all did good for A and B. It was like, okay, this was just not true.
Well,
So-
I also know for D, my husband's Honduran, and now and again I get asked to do favors for his family who are primarily Spanish speakers. And one of them was afraid to go to the health department alone because she didn't speak English, and she thought that would be a problem at our health department. So like that particular ethnic group, that might be a problem.
So you're just trying to foresee what you're trying to think of, being that, go to that advocate role, just thinking about what, hey, what could present a problem for, the children getting immunizations. So that was pretty much what that question was trying to ask. So yeah, so we're leaning more toward D because of that. All right, let's look at one more and then we will now finish recording. Let's just look at one more. A local school nurse calls the public health department to report that several students may have symptoms of pertussis. What symptoms does Mr. Brady expect to hear about?
Pertussis, whooping cough, yeah?
Yes.
G.
G.
I see heads, not anyone else. Any other answer choice?
It's G.
So why are we saying G?
Oh no, I think it's I.
So why are you say I?
Viral respiratory infection, similar to a common cold. Oh, that would be, I would be like RSV, right? So I think, yeah, it would be G. Sorry.
So G, because remember with that whooping cough, remember I mentioned that it has that distinct sound.
Yeah.
That distinct sound. Okay, and so we're going to pause right here. We are going to, I will finish reviewing and then post that recording, but we want to give you time to go ahead and look at your attestation. And so you can go ahead and work on that, because what's happening is you all are in class, you are engaged, you're participating, but for some reason you're not completing that. And that's what they look at as far as attendance. I mean, we post the recordings, we share the recordings with them, and they see you all in class, but if it's not documented, and that's the way that we document that you were in class. So we're going to start pausing toward the end and give you time to start working on that.
And don't forget, you have to go to where the grades are to actually activate it. It's not under the module, it's under the grades.
And just click there. So you can turn your cameras off and work on that. I will post this recording plus the other 2 chapters that we need to cover to be caught up. So for those of you that need to or would like to schedule a review of your exam, even if you just say, hey, I'm just curious about, what I did miss, even if you made, above 78, feel free to, reach out and schedule a time. It usually doesn't take that long. We don't have to Zoom. It could be something over
Professor.
Zoom. So send an email.
I sent you a chat.
Professor, I have a question.
Mm-hmm.
It's regarding the group project and how the submission of the peer review.
And it's actually because I have
submission is one thing, but how are we submitted it via the discussion board or submitted it to you via the peer review that is there to submit, and how is the peer review going to be done?
So were you able to access that document? First of all, were you able to open that up? Because I know that was the problem with it. Okay, and they were supposed to.
I wasn't able to open it.
Okay, so a help ticket has been submitted, and so just give it maybe another day or so. so they can go in and fix that link so that, you can go in and fill it out and complete it. And so once we hear back from that, then we'll give more instructions as what to do with that form.
I know I wasn't able to access it on my phone, but I was able to access it on my computer.
On your computer. Okay, so it wasn't
Yeah.
usable.
No, I wasn't able to access this on either,
On the
but I was
computer.
trying to find out how am I supposed to do the peer review, and particularly how do I have access to the other peers